guys ready to start? Good evening, guys. I'm Dr. Ajay Yeddu. I thank all of you for coming for this talk presentation. I'm an anesthesiologist and I practice interventional pain management in Phoenix for the past 30 years. My son Suraj, he goes to biomedical engineering here. But regardless of whether he's my son or not, I hope you'll learn something from this talk because there's a lot we do in interventional pain and anesthesiology. Well, this is where it all started. This is my elementary school and middle school back in India. That's my school. I just wanted to put that picture in because you can see that how kind of like primitive or elementary it looks. And if I can go to school like that and be successful as a doctor here, if I can do it, you all can easily do anything you want. So that's kind of like a motivational picture, so to speak. This is where I went to medical school in India. This is a college in the southern state of Andhra Pradesh. So I went to school, medical school right after high school. And that's how the system is set up in India. You don't have to do a four-year college. But the medical school is a 5-year school. And then you have to do a 1-year internship mandatory. So you can say it's a 6-year medical school. So it makes sense how you can just go straight from high school and spend 6 years in medical school. When I came to US, this is where I lived, Madison, Wisconsin. This is where my re-education started. Going to medical school in India, you almost learn nothing compared to what they teach you here. This is more clinical medicine. In India, it's all textbook, theoretical medicine, where the questions are like random. Who knows the most knowledge is what they test in India. Here, who can apply their knowledge? So you can have all the knowledge in the world, but if somebody says, hey, I'm nauseous, what can you give me? And from my training in India, I'm like, I don't know. So anyway, this is where I spent 5 years relearning medicine. I used to go to grand rounds. I just showed up in the Department of Internal Medicine. I followed their schedule. They have grand rounds. They have CME meetings. I go morning meetings, rounding with the patients. I learned a lot. So anyway, it took 5 years for me to, again, this is a motivational thing for you guys. Multiple attempts. 5 years to pass the United States medical licensing exam. And then it's a struggle. No, sorry. It took 3 years to pass the exam, but it took 2 more years to get into residency because, of course, if you have a number of attempts, you're not good enough. So this is my saving grace. In Montefiore Medical Center in Bronx, I went for anesthesia unpaid research. They were doing, at that time, this is in exact 2000. Year 2000, there were propofol isn't brand new at that time, so we were experimenting on the lab experiments on the neuroprotective effects of propofol on rats. So I think this is what landed me into anesthesiology residency, which also at that time is a walk-in type of thing. Anybody who wants it can get it. At that time, family practice is a lot harder. You can get the best course you want, you're not getting into family practice. Anyway, so everything is cyclical. So there's no such thing as anesthesia being great. Yeah, maybe it is now. 10 years from now, nobody might want to go in there. Same thing with surgery, same thing with radiology, same thing with family practice. I got matched in LSU Shreveport into anesthesia residency right after, less than 6 months after I did the research, I got selected here. And again, motivational thing, this is my only interview and this is my only selection. It's not like I have 10 things to choose from. It's not like I got into other programs. I thought anesthesia is a movie. Anastasia, that's the only thing I know about anesthesia. But again, once you get in and know what it is, it's one of the best fields to be in. After 4 years of anesthesia, I went into pain fellowship in Seattle. That's a 1-year fellowship, which should actually be a 2 or 3 year fellowship because there are a lot of things. Pain management has expanded unbelievable in the last 10, 20 years. This is my own practice in Gilbert. Started in 2010. Used to be under a different name before, in 2008. So this is just a general summary of what we do. Most patients or even doctors think pain management is nothing more than shooting steroids in people's back, and that's the only thing they know. And they could not be more wrong, because pain is becoming like a mini orthopedic surgery or mini neurosurgery. I'll show you pictures of some of the things we do, and it's still evolving. So that's generally what we do. When it comes to, these are bread and butter. This is what everybody was doing in pain management for the last 50 years. You name it. You give me a needle, you give me an x-ray, and you tell me where your pain is. I'm going to slam back it, put a needle every single time, exactly where you need to go. This is old school, but the newer, I'll show you. So let me show the picture of the spine. This is basically your basic anatomy of the spine. I want you to look at those three spots. So this is the axial view. So that's the anterior, front, the posterior. So the disc and the vertebral body. So the vertebral body and the intervertebral disc. That's what's shown here. So the spine is like a tripod. You have a disc in the front, and then these two guys, like this one and this one, the facet joints are on the back side. So that would be the facet joint between the spinous process. So it's a triangle. And in between those three contact points, you have the spinal canal with the spinal cord in it. And then the spinal nerves come out like branches of a Christmas tree. So you have a spinal cord like a trunk, and the spinal nerve like a branch coming out. So all the problems with anything with back pain or neck pain or spine pain come from inflammatory effects of either the problems with the disc or arthritic or inflammatory changes in the facet joints, causing the ligamentum flavum, this muscle can become swollen. And when it's swollen, what is it doing? It's pushing forward. When the disc is out of place or inflamed or herniated, what is it doing? It's pushing back. So everything is pushing into this empty space because it's a free space. Nothing stops anything from pushing in there because there are muscles on this side, and then there are a lot of muscles on this side. So there's no space to push other than into the canal. So anyway, just remember this one picture for the future slides for you to understand better. So these, again, going back to the previous slide, so that facet joint on the lateral view look like this. Those are the joints on the left side. You have more joints on the left other side. So some people have a lot of back pain, not because they have a pinched nerve, not because they have a bulging disc, but because they have an inflamed facet joint or arthritic joint with muscle swelling. So this procedure is all about cauterizing the small nerve branch. I call this as a root canal treatment of the spine. It's just like a dentist cauterizes the nerve in the tooth. And that's the one thing patients ask me, hey, if you kill the nerve, would I be paralyzed? My answer is no, because I'm not touching any of these big nerves. Those are motor or mixed nerves, motor and sensory. They're only cauterizing this tiny nerve ending. Just like your face won't get paralyzed when you have a root canal, your back or nerves won't be paralyzed from this procedure. A lot of advanced procedures for facet joint pain. So these are just examples of some of the injections I did. So the SI joint is basically a pelvic joint. It's one of the strongest joint in your body. The sacroiliac joint connects your top and bottom, upper body with your lower body. You more likely strain or sprain or throw out your sacroiliac joint than you throw out your disc. The study showing 70% of all back pain come from sacroiliac joint, as opposed to people thinking until this time or recently, the only thing everybody used to focus on is on that disc, as if nothing else mattered. But there are a lot of loose parts to the spine. So anyway, this is my sacroiliac joint injection. You can see the both joints. That's the front of the joint. So this is a patient laying face down. That's the right-sided SI joint. Again, just a knee injection. It just shows the contrast in the joint. So all my injections are fluoroscopy guided because otherwise you have no clue what you're doing. Or you can't, you have nothing to show for it. This is basically a shoulder joint injection. You can see a little contrast in the glenohumeral joint. Hip joint, again you can see like a mushroom shaped contrast going into the joint. So some of the advanced procedures we do, I think this is where it gets interesting. I'll outline some of them because I have videos to show. Kyphoplasty is when people have vertebral compression fractures from bone loss. So what all they do is some of these old folks in their 80s, 90s, they wake up in the morning and they have pain. Just the force of landing their feet on the carpet is enough to compress their vertebral bodies. I'll show you videos of all this because it makes it easier to understand. This one is basically vertebral augmentation for vertebral compression fractures.
Kyphoplasty, balloon vertebroplasty. This minimally invasive procedure repairs a vertebral compression fracture. It helps restore the spine's natural shape. Some patients experience rapid pain relief after the procedure. Before the procedure, you are anesthetized. The physician guides the needle through the skin of your back and into your fractured vertebra. A special X-ray device called a fluoroscope helps the physician position the needle. A balloon device is placed through the needle and into the vertebral body. The physician carefully inflates this balloon to expand the fractured bone. When the balloon is deflated, it leaves a cavity in the middle of the vertebral body. The balloon is removed. For some patients, more than one needle and balloon may be used. The physician injects bone cement through the needle. The cement fills the cavity. It hardens inside the vertebral body, stabilizing the fracture. When the procedure is complete, the needle is removed. The opening in your skin is closed. Your doctor will give you instructions to aid your recovery.
Yeah, so the few things about this. 10 years ago, I used to put patients under general anesthesia. It took 2 hours for this procedure. It's an open incision, 2 inches long. Neurosurgeons or orthopedic spine surgeons take you to the hospital. They call it 24-hour admit to check in. They cut you open, expose the spine, then put a needle into the bone to do exactly the same thing. Earlier, they used to get a bone graft from the iliac crest. So they make another incision here, scrape off your iliac crest, you have a surgical assist, literally grinding the bone into a pulp, then load up in a syringe and inject it this bone. So now, I did this procedure today at 4 o'clock. It's an 8-minute procedure per level. So that's how far, and this is in my office, not in an ambulatory surgery center, not in a hospital. So I think things have advanced so much, and this is not even a newer procedure. I've been doing this for the last 10 years. What happened with this procedure is the reimbursements went down so much. The surgeons and the hospitals don't want to take a pay cut for doing this procedure because their OR expense is more than what the insurance pays them. But if I do this in my office, I don't have OR expenses like a hospital. So this is a different procedure. I want to emphasize here, again, you're looking at the spine, the anterior and the posterior. So people think when you have a spinal stenosis or narrowing of the spinal canal, the theory is, well, only a disc bulging can push and narrow the spinal canal. This is more common than a disc pushing it. So that's basically the facet joint arthritis causing ligamentum flavum swelling or hypertrophy. So this is a type of stenosis where you don't have to go to a surgeon. You can get benefit from somebody like us, interventional pain or interventional radiology.
Mild procedure. This procedure treats lumbar spinal stenosis. That's a narrowing of the space around the spinal nerves in your lower back. The mild procedure makes more room for these nerves, relieving painful compression. To begin, you lie face down. You're given medicine to help you feel relaxed. Your lower back is numb. With the help of a fluoroscope, that's an X-ray device that shows video images, a needle is carefully guided into your spinal canal. Contrast dye is injected into this space. It shows a clear view of the compression. Next, a small opening is made in your skin. The surgeon inserts a hollow tube called a portal and carefully pushes it down to your spine. Thin instruments are placed through this portal. The surgeon uses them to remove small bits of bone and overgrown tissue from the part of your spine that forms the rear of your spinal canal. This relieves pressure in the spinal canal. It gives your nerves more room. When the procedure is
again, so with this procedure, so this is so effective, this procedure. 2 years ago, Medicare, this problem is more common in older population because they have this ligament gets calcified. So that's the main reason why they have stenosis. That's why old people, you find them leaning forward because that's a comfort position and they stand straight. So not everybody with back pain, don't tell them if you stand straight you'll be fine. No. If you stand straight you're miserable with this problem. So anyway, Medicare doesn't even require a pre-authorization. If somebody has this problem, an MRI, of course, you can just go do this procedure and think about payment later because it's automatically approved. This is another area I'm interested in. Like I was mentioning before, how this SI joint is one of the major 70% of back pain. So we're trying to put orthopedic surgeons out of business with this procedure because what they were doing so far, I think, is unnecessary, bloody, and too many complications. And so the company, the CEO is a triple Harvard degree. He actually he moved to Scottsdale recently. He's a Harvard business, Harvard biomedical engineering, and Harvard medicine. He sold one of his crew to Stryker for multi-million dollars, and now he's keep on developing more products. Watch this.
My name is Dr. Kingsley Chen. I'm a board certified orthopedic spine surgeon. What I'm going to discuss with you is a new technique and how you can use the sacroiliac joint. The sacroiliac joint can cause pain that you feel around your back, and it's due to instability of the joint, arthritis in the joint, trauma around the joint,
So this is another, so the last, I think this is the last video I'm going to show you. So this is all about vertebrogenic pain. People have back pain. It's not all about the disc. It's not about stenosis. It's not about the facet joint. Just like you can have a vertebral compression fracture, people can have pain in the vertebral body itself. And this is the Intercept is a new procedure, brand new, 2 years old. After 10 years of development, it has its own ICD code, the billing code, and the FDA approval.
Chronic low back pain impacts millions of people in the United States. While there are many causes of chronic low back pain, one cause is pain transmitted from the basivertebral nerve, which is found within the bones of the spine, called vertebrae. Research has shown the basivertebral nerve has the ability to transmit pain and contribute to chronic low back pain. The Intercept procedure is a new, minimally invasive procedure that targets the basivertebral nerve for the relief of chronic low back pain. Following a 3 to 5 millimeter incision, an introducer is advanced into the vertebrae. A curved instrument is utilized to create a channel to the trunk of the basivertebral nerve. The radiofrequency probe is inserted into the curved path and placed at the trunk of the basivertebral nerve. Radiofrequency energy, or heat, is used to ablate the basivertebral nerve, rendering it unable to transmit pain signals. In a clinical trial, patients that received the Intercept procedure experienced a 48% decrease in their disability levels at 3 months after the procedure, and these levels were sustained through 24 months. The Intercept procedure is a new, clinically proven treatment option for the relief of chronic low back pain. The Intercept intraosseous nerve ablation system is intended to be used in conjunction with radiofrequency RF generators for the ablation of basivertebral nerves of the L3 through S1 vertebrae for the relief of chronic low back pain of at least 6 months duration that has not responded to at least 6 months of conservative care, and is also accompanied by either type 1 or type 2 motor changes on an MRI. The information provided by Relievant Med Systems Incorporated is not intended to be a substitute for professional medical advice. The Intercept procedure, as with any surgical procedure, has risks that should be discussed with your medical professional.
Okay, yeah, I guess this is my last one. So this, if you ever heard of spinal cord stimulators, that's something we were doing for the last 20 years. Let's watch this video and I'll explain.
To understand why the Buzzy technology is so effective, you need to understand the physiology of pain. Imagine you burn your finger and you put it under cold water. Instantly the pain disappears, right? The reason that cold water decreases burn pain is not because a burn is hot and water is cold. The reason is because pain nerves are really easy to overcome. All pain, whether it's burning pain, sharp pain, even itching, travels on a very small nerve called the A delta fiber. Now the A delta fiber is insulated with something called myelin, and it's so heavily insulated that it can transmit signals very quickly. Thing is, the only reason your body really needs to know about pain is for you to get away from it. Once it continually stimulates you, it causes inflammation, it causes problems. So for this reason, this A delta nerve is tiny, very, very thin. Now, a more important signal for your body to recognize is motion. You need to know where you're moving, where you are in space, if someone's touching you. You need to be able to distinguish light touch from heavy touch from really strong touch. And so those nerves are called A beta fibers. They're also very heavily myelinated. They have a lot of insulation, so the signal can travel really quickly, but they're much larger because they have to transmit not only the degree of information, but also a whole spectrum. So think about this. What do you do when you bang your hand with a hammer? Immediately, you start vibrating your hand. What do you do when you bump your elbow? Immediately, you start rubbing it. Now, the other kind of sensory nerve you need to know about is called a C fiber. A C fiber is more from a constant pressure or from cold or from chronic pain. This one's not insulated. It doesn't have something that tells you the information really quickly. Instead, what it does is it builds. So the longer you're pressing, the longer you have your hand in a bucket of ice water, the more intense that sensation gets. The C fibers are transmitting information continually, and it gets stronger over time. So, okay, how does this have to do with Buzzy? So all three of these nerves, pain, motion, and cold, come together in the spinal cord in one area. One final signal is transmitted to the brain. So if you overwhelm the sensation of a burn or a bump with enough vibration, with enough cold, that pain sensation disappears. This is called gate control. The idea is that there is a gate in the back of the spinal cord that will block out the smallest sensations and just transmit the sum. So when you take a Buzzy, the vibration and the cold behind it is actually stimulating those A beta and the C fibers to block out the sharp pain of a shot. That's the pain physiology of gate control.
Okay, yeah. So I don't know what Buzzy was, but I guess it's called a TENS unit, transcutaneous electric nerve stimulation. There are like 100 products in the market. So remember, she just mentioned the pain traveling on the back side of the spinal cord. That's exactly what we do with the spinal cord stimulators. If you put a stimulator on the skin or on the back, it has to go through all the barriers before actually stimulating the spinal cord. With the spinal cord stimulator, you're directly taking that into your own hands. So it's much more, tens of times more effective. So anyway. So those are my cases, those spinal cord stimulator placements. That's how the leads look. They're situated directly on the back side of the spinal cord. You can see that being the midline, the spinous process. So it's placed on either side of the midline. We do a trial. We put these leads in, send the patient home, ask them to come back 5 days later. Those wires or leads are connected to external battery. And then they try it for a few days and come back and say if it's good or not. If it's good, that battery will get implanted. The leads stay in place. If it's not good, you just pull the leads out and then move on to a different treatment. So those are my cases for kyphoplasty. This is a lateral view. So that's the balloon and that's the actual cement. So the next space we are going into is interspinous spacers. So again, this is a competition with orthopedic spine and neurospine. We want to make sure the pedicle screws are out of business. Because whatever you can do with a screw and a rod put in your spine, you can achieve almost the same thing with a spacer. And there are 20 or 30 different spacers. This is called vertiflex. So the spacers are meant to increase the size of the foramen, the neural foramen. Where if you have a pinched nerve, you can basically increase the height of the foramen and fuse the spine that way. Anyway, it's a kind of a different approach. This is the in-span spacer again. So this actually has teeth biting into the spinous process. It's more sturdy. It's actually more sturdier than pedicle screws. In a recent article last week, 2 weeks ago, I don't remember the journal, they compared pedicle screw fusion versus interspinous fusion with in-span, and they found this is not any less inferior, and it's superior in terms of post-surgical complications. So these are my cases of sacroiliac joint fusion. So this particular case, this guy is a motorcycle accident 20 years ago, and he has a pelvic fracture. His pelvis is fractured all over. He has a pelvic symphysis fused. You have a sacrum and ilium fused with this one board. That's what all they had. It's like a crude instrument, one board going from here all the way almost to the other side. He still has pain, so we put 2 screws above and below. We call these compression screws. You can see the threading on it, and then the windows of the bone marrow graft. So as you advance the screw, actually the joint is getting tighter. So the 2 bones are pushed together, and that's the advantage of these compression screws versus a bolt or a nail. Again, this is another case. This guy already has his back fused. Well, yeah, that's what a fusion would look like. The critical screw fusion would look where the surgeon actually put screws, 2 at each level, and then a rod to keep the screws in place. Anyway, so once you have a spinal fusion, you're most likely to have a problem with SI joint because we call that adjacent segment degeneration. So you can have a pain below the fusion or pain above the fusion. Or you can have a 2-level fusion and then 10 years later, guess what? The disc above the fusion now it's out of place. Or now they have pain. But the SI joint is painful. So this is a SI joint fusion in patient after back fusion. So I think we're at the end of it. Those are my words of encouragement based on my own experience. So I didn't go to good enough school. So if I just learned what all they taught me at school, I wouldn't be where I am. And I aimed higher. So now in my anesthesia class, actually I'm the only one who actually got admission at the University of Washington, Seattle. Nobody else who applied got it. I was lucky, but I'm just saying you have to keep aiming higher. And then I tell my son this: if you know your potential, most likely you'll find out you're not as good as your peers or colleagues. So if you know who you are, you know what you need to do to get where you need to get. It's not time to say, you know what, I'm not as good as somebody else. So if you're only half as good, that means you have to work twice as hard. Plain and simple. If somebody twice as good is studying an hour, you got to study 2 hours. Unfortunately, like everybody's intelligence is different. It's not enough to say, you know what, just deal with it, you're not smart. No, you're not smart, but you can work hard. So anyway, so this is a habit, and I encourage all of you, if you're interested in medical school, it gives you the most satisfaction from doing it. It's hard, it's not easy. I missed out all my 20s, to be frank. Would I like it at that time? No. Do I like it now? Yes. Because unlike, I don't know the other fields. I don't sit in meetings. I don't wear a suit. I don't have corporate tell me what to do. I just go see patient. Then it's very gratifying when patients, you get feedback from them. If the patients are not getting better from what you do, they have no reason, no business to come and tell you how good they feel or thank you for anything. So that's a gratifying feeling, and you call the shots. You do what you need to do, and you don't have a timetable to see what pays you the most. You don't have to worry about payments. What all you worry about is benefit your patients. They like it, you like it, and once you're doing your job, you all get paid well. So it's a long school, but I think if you're interested in it, don't let anybody discourage you saying, you know what, you can go to a 4-year nursing school and make the same money. You can become a CRNA for an anesthesiologist. One of my colleague anesthesiologists used to say, I wish I went to CRNA school after becoming an anesthesiologist. So I'm saying, yeah, be what you can be, because it's definitely gratifying. And other than just learning new things, attending conferences, I think the amount of work I do or spend time educating myself now is a lot less than like compared to a lawyer has to read up 5 to 6 hours every day. So you basically put everything in the front end, learn everything in your 20s and 30s, and then you have a better life later on. Anyway, thanks for inviting me, and hope you learned something from this, and if you have any questions, I'll be happy to answer. And good luck with your midterms.
All right, guys.
Yeah.
So you mentioned this procedure called where you like dissect the heart or like destroy some tissue that's like nervous tissue. What is the success rate or like?
Oh, so you're talking about the radio frequency?
I think nerve ablation.
The nerve ablation. So so there's a kind of like a theory behind it. So when you kill a nerve, you're taking away the pain temporarily, right? The nerve grows back. It grows back 100% of the time. But it takes 15 months for the lumbar nerves to grow back. During the time when you don't sense or have any pain in the joint, two things happen. When you kill that nerve, you paralyze a muscle called multifidus muscle. It's a big muscle on the back side of the joint, holding the joints together. So by paralyzing that muscle, again temporarily, you make the joint more hypermobile, more mobile. And that's number one. Number two, you don't have any pain. So you're actually grinding and polishing those joints. And joint remodeling might take 3 to 6 months to happen. So by the time nerve grows back, it's finding itself a nice clean joint to grow into 70% of the time. So meaning there's a 30% chance your pain can come back after a year. And then the percentage doesn't change. If you have that ablation of nerve burning a second time, 70% of those 30, which is what, 20 of them, are not going to have the pain come back a third time. So between two treatments, a year apart, or let's say 6 months to 18 months apart, we're talking about up to 90% of the patients getting better.
So
So its success goes higher and higher, not lower and lower.
The procedure itself allows for the bone to reshape.
So you're giving it a break. While you're sealing, you're not hurting it, and by hurting it, you're not spasming your muscles. By spasming your muscles, you're now locking the joint. By locking the joint, you're causing more damage or trauma. So a stagnant joint is always a bad joint. A joint is always supposed to be in motion. Yeah, go ahead.
Yeah, that's basically what I was gonna ask. Like, if you do you remove the sensations from the nerves? Would the pain and the causes of that pain still be there? And so
You'll be there until if you're unlucky where you're not able to completely grind the joint down. So let's say you fail to get relief from that after 2 times. So then the other procedures, now you have a facet joint screw, screws across the facet joint to stabilize it. And then regular surgery where they clean the facet joint, surgical facetectomy. So unfortunately, there are always more aggressive options for every problem. So what we are trying to do in interventional pain, interventional radiology, is try to minimize tissue trauma without downtime, without non-weight bearing, and minimal incisions, and make people better. And because there are a lot of options out there. And then now there are endoscopic spine discectomies. And again, it's a tough war. If you're in an orthopedic pain group, the orthopedic surgeons don't want you to do any of those because it's their money. But then if you're independent pain practice, you have your own surgery center, your own clinic, insurance approve it, I will do it. Yeah.
How is your industry growing right now? How do you project the technology to get better?
Oh, it's interventional pain, interventional radiology, and some of the neurology, physical medicine and rehab. All those are going to come under a big conglomerate. Interestingly, just this week we're talking about WhatsApp group. There's a big interventional pain and spine group. We're trying to come up with a new name, a catchy name. You can give us ideas if you have any. I was trying to call it like minimal interventional spine treatment, or there's a group called less exposure spine surgery. So you want to start an organization with the dues, membership, annual meetings, and expand that. Because 90% of all interventional pain doctors, what all they're doing is prescribing oxycodone, hydrocodone, morphine, and doing these epidural steroid injections like there's no tomorrow. You go there 10 times, they do 10 injections without any reason for it. And they're not going to get any better from it either, the patients. So it's going to expand. It's going to become a tough war where, like I said, with kyphoplasty, we are doing what orthopedic surgeons used to do as a 2-hour surgery. We do it in 8 minutes in the office. The lady I did today is 84 years old. The oldest lady I did in my office. Even I can't believe it that I put a 94-year-old lady who's comes on a stretcher from a nursing home to get on my office table in my office, do the kyphoplasty, and walks out, meaning walks in a wheelchair. transporting, because when she came on a stretcher, she can't even sit up. Sitting up itself causes more pressure on the vertebral body. That's how painful she was. So yeah, it's a growing field. Yes.
So, what I know that the demographic is very older.
Mm-hmm.
However, what are the percent chances that, like for example, when I'm 80, will have to come see you?
Even higher. So basically, with all the smartphone use, the study showing people have an increase in neck surgeries and neck treatments, cervical injections, and so there's more problems with the smartphone use. And then there's no such thing. If you're 80, it's not like you will have to come, you will have pain. But what's the likely chance that 80-year-old 20 years from now is going to be more active than 80-year-old now? Probably higher. So the more active, the better for you as a doctor, because they're going to hurt themselves. So somebody sitting at home watching TV is not going to twist their ankle. The one who's on the skateboard is a gold mine for an orthopedic surgeon. So that's why there are more orthopedic surgeons in Pittsburgh than anywhere else in the country. Because it's all hilly, snow, people are breaking their hips, twisting their ankles all the time. Yeah.
Do you have a favorite type of procedure that you do, like a personal favorite?
Personal favorite, it's almost exhaustingly or frustratingly favorite thing is the SI joint. Because when I came out of fellowship training, nobody told me I would see 70% of all back pain. Actually, that's my only claim to fame, is that somebody goes to 10 different doctors for the last 10, 15 years. And then they come to my office, I can see them limp when they get off from their chair. And after they walk for 2 minutes, they're not limping anymore. Okay, that's typical of SI joint pain. It locks up when you're not doing anything. When you get up in the morning, you're stiff. After you walk for a while, you're not stiff. You're not hurting anymore. And then the doctors tell them, hey, you have a hip problem. I'm like, no, you don't. If you have a hip problem, the more you walk, the more you should hurt. If you have a disc problem, when you're upright, you have more pressure on the disc. When you're supine, you're decompressing your disc. So it doesn't make any sense. You should sleep like a baby if you have a disc problem. But then towards the end of the day, you're miserable because you're loading your disc the whole day. So I keep finding all these patients with SI joint pain. And the travesty here with everything is money. I mean, the world runs on, it's always in the background. So if people get a sacroiliac joint injection, the insurance pay like $70, $90. If you do a epidural injection or a true level transfemoral injection, you can get $500. So I don't know if money is the motivation. The bottom line is, I kept seeing all these patients with sacroiliac joint pains, sciatic pain, all these doctors, they never got better. And then they would ask me, oh, how come all those guys never diagnosed me? And I even got tired of answering that question. Because there's no way I could honestly answer that question without bad-mouthing the other doctors who are all my friends and colleagues. So you don't want to complain about other doctors with non-doctors. So you still want to, so anyway. So that's unfortunately, that's a reluctant favorite thing to do is fix people with SI joint pain. And I have done that screws I showed you that I've done like $200 in the last 2 years. Before COVID, that procedure didn't exist. What I would do is I would diagnose somebody with SI joint pain and do injections. They're like, you're the best. I even got a present from a patient saying that Yeddu's miracle oil can. So you cannot lie to them. They know what they feel. You don't have to tell them or brainwash them saying, oh, you're feeling better from what I did. No, they don't. So anyway, so in the past, these people can have repeated recurrences of pain. The injections are not doing anything permanent. I would send them to a surgeon, and the surgeon would say, no, you don't have SI joint pain, go get a spinal cord stimulator. I'm like, no, I'm not going to put a stimulator on this. So the spinal cord stimulator, regardless of how good it is, So if you break your ankle skateboarding, you're not a candidate for spinal cord stimulator. You fix the problem first. So the same thing with SI joint pain. If your joint has a problem, you cannot cover up the problem with a device that's going to stay in your body for the rest of your life. So there's a lot of mismanagement. So I think my goal is to fix the problem, and then if you still have pain, then the spinal cord stimulator is mainly for people with failed back surgeries. So they did everything that they are told to do. Their problem is the overgrowth of nerve endings. All these surgeries and scar tissue cause a neuroma type of pain, like excessive nerve growth around the scar tissue. So that's where the pain is coming from, not from any organic cause. And those are the patients are excellent for spinal cord stimulator. I even put pain pumps, intrathecal pain pump, just like a stimulator, you put a catheter in. A patient with Lyme's disease, a tick bite, he's like 26 years old. That's why I don't like camping. 18 years, when he was 18, he went camping, tick bites, like polyarthritis. Arthritis in every bone you can think of. So what do? Do you give them a 100 milligram oxycodone? No. So again, the spinal opioids, you can cut down the doses 100 times because the opioid receptors are on the spinal cord and the brainstem. So when you take oral opioid, it goes through your liver, lung, kidney. You're destroying your vital organs. And then it passes through blood-brain barrier. Now you're talking about tolerance, addiction, all the side effects, and dependence. So everything happened from opioid effects on the brain. So after it goes into the brain, then the opioid travels into the spinal cord. That's where the site of action is. So to deliver the medication to the spinal cord, you're going the roundabout way of putting that medicine in your mouth. So that guy with Lyme's disease, polyarthritis, he has a intrathecal pain pump. Again, it's just like insulin pump. It stays in the body. You fill it every 6 months. When the battery runs out in 8 to 10 years, you put a new battery. They're not getting addicted, they don't have tolerance, they're not on high dose. All the opioid problems we're talking about right now wouldn't affect them. So, and they have better pain control. They don't have to come to your clinic every month. You see them every 9 months. Anyway, guys, thanks for giving me this time. And any more questions?
You were talking about with him the surgery that you like cut out or something, like you cut out or destroy some of the nerves like in the back. You said it like paralyzed the muscle. How long is it paralyzed for?
Until the nerve grows back.
Would like atrophy of the muscle be like a problem at all?
It is a problem. Not from the procedure, but the multifidus muscle is the key. You can Google this multifidus. So there's no new theory on multifidus muscle not being strong enough on people with back pain. So there's a new stimulator called Reactive 8. So it's a stimulator which actually stimulates the multifidus muscle to improve its strength. I haven't used it, but I can see the theory behind it. And also on MRI, when you look at the axial views, so in MRI, when you look at the axial view, you can see the size of the muscles, and you can clearly see people with multifidus atrophy. I think most multifidus atrophy happen from people having long-standing issues with back pain, where they lose all strength, the back becomes weak, they are not conditioning themselves, and then the muscle is completely gone. You don't see it like you see on your biceps or calf muscle. It's all internal, way under the skin, because they are the third layer of muscles, not the erector spinae muscles. They're like third layer deep next to the spine. So on the outside, you see these people as fit and lean and skinny, still have back pain. They don't have those multifidus muscle. But there are no studies showing, just like when the nerve grows back, the muscle grows back, and the facet joint innervation grows back. So those multifidus muscles are not supporting your legs or anything. They're just right on top of the facet joint.
Okay.
Yeah, you can actually weaken the spine. Yeah, you know, during the time when you don't have those nerves, your spine is weak. So basically, you tell them to strengthen their. Keep doing some exercise.
Okay.
Okay. Thanks a lot.